Good evening, or well, no, good lunchtime. Thank you to Medac for putting this together, and thank you guys for giving us this time to talk about what I think is a really important area of interventional oncology. I'll try and share a quick PowerPoint presentation with you. So I'm going to talk through the evolving role of chemosaturation, how it's evolved over the years, and where we're at the moment. And I think to give it some perspective, we should go back 40 years almost. Originally, there was a system of surgical isolation of the liver. So that involved putting big clamps on the cava, on the IVC, and then injecting chemotherapy, and that was an alkylating agent, normally melphalan, into the celiac axis retrogradely through the GDA. And the surgical outcomes, and this is a long time ago, demonstrated clearly, if we look at the table here on the right, that when you look at those patients that had IHP with hepatic arterial infusion, their median progression-free survival was significantly greater than those patients that didn't. So even this very early data gave us a very strong signal that isolating the liver and saturating it with an alkylating agent works in terms of controlling liver disease. Now, I realize there's probably some tension between you and your Swedish neighbors, but I thought we had to give credit where credit's due. The original work, or a lot of the original work, was done by the Swedes. This is one of the original papers, 1994, looking at irresectable liver disease and looking at isolated therapy, isolation therapy, in 29 patients. And they demonstrated even back then that they could get good control of liver disease using surgical chemosat, surgical liver isolation therapy. Now, I would say the Swedes, having done well in 1994, moved on to probably not quite the greatest move in that this trial they set up, the Scandium trial, is currently open and looking at patients with uveal melanoma, so eye cancer, and looking at the same technique, isolated hepatic perfusion, so surgical isolated hepatic perfusion for management of disease. Now, how can that make any sense? We do know from the old data that isolating the liver surgically and infusing an alkylating agent gives good control of liver disease. But what anyone will tell you is that going through a treatment analogous to a liver transplant is a massive hit on the patient. And like most cancer treatments, if it works, what do? We do it again. And you can't do it again if you're talking about the surgical technique. It's a once-only treatment. And yet this trial was set up despite the fact there was clear evidence from the interventional oncology community that we could deliver this treatment percutaneously. And in delivering it percutaneously, we could reduce the morbidity, the mortality, and we could also repeat the treatment. So the Swedes, having done well in helping develop the technology surgically, I think were probably faulty in thinking that running a randomized trial for uveal melanoma using a surgical technique was of any value. But what I want to talk about is how the treatment has evolved. We've gone from a surgical treatment to the ability to isolate the liver. So you isolate the liver by putting a balloon in the right atrium and impacting it to stop the blood getting back into the heart. You then stop flow up the cava with another balloon. And when with those fenestrations, so there are fenestrations here along that venous catheter, allow you to suck the blood that's coming out of the hepatic veins. On the other side, we can saturate the liver. So with a catheter in the hepatic artery, we can saturate the liver with chemotherapy. We can put in whatever we want. And then we have the ability, using the vena-venous bypass circuit, so the blood is sucked out from the hepatic vein outflow. This is just a pumping mechanism to keep the blood flowing. Blood's fully heparinized. We put it through this proprietary filter, and that allows us to clean the blood of chemotherapy. Now, the latest generation 2 filter, it's about 92% effective, so incredibly effective at reducing the dose of systemic chemotherapy the patient gets. So what we do in effect is deliver a massive dose of chemotherapy to the tumors and very little drug to the rest of the patient. So the problem with most conventional chemotherapy agents is we're limited by systemic toxicity, whereas with this treatment, that's not a big issue. How does it look in real life? So you can see here an arterial catheter, 5 French catheter in the celiac axis, microcatheter deep out into the liver. We put some coils here, GDA, left gastric, and probably a gastrohepatic. Now, we don't bother doing any of this coiling anymore. This was some of the original images from, this is 2012, so a long time ago. We don't bother with this pre-treatment embolization anymore because we feel safe in the knowledge that the safety profile is so good with the treatment. But what we do, we blow up the balloon in the right atrium. You then pull it down and impact it, and you get this acorn shape. That shows you've impacted within the IVC, and that takes a bit of tension, so manual tension. You then blow an inferior balloon up. So the second balloon here, you see the flattening on the walls of the IVC, so you now know you've got this segment isolated. To prove it, we do a venogram, so we stop the vena-venous bypass. We inject contrast retrogradely through these fenestrations, and what we want to do is see hepatic vein filling, but we don't want to see leak into the right atrium. So if you get that image, you know you've got a good seal. What you do then is you put the filter in circuit. So you open up the filter. So up to that point, we can run the blood around the circuit without going through the filter. So this is a bypass line here. We can then put the filter in circuit. What you do see is initially when you blow the balloons up, you get a drop in hepatic output because, of course, you're reducing venous returns to the heart. You can resolve that with filling and with other clever anesthetic tricks. When you put the filter online, you do get another hit to cardiac output, and that seems to be a systemic effect, a bit like a SIRS effect. So you get an inflammatory response, but that's again transient. And if you know how to manage it and you've got the right agents running, that causes us minimal problems in this day and age. And then you run the circuit and you run the chemotherapy. Now, where do we start in terms of evidence base? Well, we have to go back to the original trial, closed in 2009 from memory, done mostly in America, 93 patients, and they were of patients with melanoma which had metastasized the liver. Now, one issue was they had cutaneous melanoma patients in this patient population, and that was an issue, as I'll show you when we talk about uveal melanoma. They randomized them 1-to-1. The second issue was in the best alternative care arm, anyone that progressed was allowed to cross over and have the active treatment. And you can see 55% of patients went on, who were in the best alternative care arm, went on to have the treatment. And that meant it was very hard to analyze because very few patients didn't have chemosaturation. What the trial showed, again, is that in terms of controlling liver disease, and that's all you can ask a liver-directed therapy to do is control the liver disease, it's incredibly effective. So the difference in the two groups between hepatic progression was 1.6 months without chemosat, 8 months with. So this treatment undoubtedly, just like the surgical treatment, is good at controlling liver disease. The issue, though, in the original trial was that with all the crossover and with the safety issues, we couldn't prove an overall survival benefit. But I'm a bit of a cycle fan. This is Brailsford here, Chris Froome, who's won the Tour a few times. What the Sky team have done is demonstrated little incremental change, little differences add up to a big difference. So whether it's moving your GPS bike computer back a few millimeters so you reduce turbulent flow, whether it's these Sky shirts which are meant to increase aerodynamic flow over them, these are subtle baby differences, but they all add up. And I would say now at Southampton, we've done over 300 treatments now. What we've done every time is just to keep on learning, keep on improving. And they're small differences, but again, they add up. And what they add up to is easier patient throughput, less length of stay, and less morbidity for patients. So after 300 patients, we've had no deaths. Patients don't go to intensive care unit anymore. They just go back to normal surgical recovery. And our average length of stay is down to 2.5 days. So that's a massive difference from where we were when we started. So what I would say is this is an evolving technology. This is our data published a few years ago, combined with Moffitt in the US. This is a waterfall plot. And what it shows is, again, there's a strong bias towards complete response, partial response, or stable disease. So there are few patients who are unmeasurable and very few with progressive disease. But what this shows is, again, as the surgical data did, is this treatment is incredibly effective at preventing liver progression. And added on to that, you can get good partial response or complete response. These were our waterfall plots. This is to do with ocular melanoma. So when you see median survival out near 2 years, that doesn't sound particularly exciting. If you work in a field of uveal melanoma, that's a standout figure, as I'll show you. So undoubtedly, we're getting good overall patient survivals with good safety profile now. Now, I know this is a talk about chemosaturation, but it is important to focus a little bit on uveal melanoma, because uveal or ocular melanoma, same disease, has an important pathway here in terms that this is now probably the standard care or gold standard care for these patients. So what we should say is malignant melanoma is an aggressive disease, and malignant melanoma develops from melanocytes, so pigmented cells. But the tumor biology between cutaneous and ocular melanoma is hugely different. So cutaneous melanoma, much more common, 90% of cases. The primary is often, on your arm, on your leg, on the skin. Management involves surgical resection. So you remove the primary, and then you're looking for spread to regional lymph nodes, whether in the axilla, whether in the groin. And they spread in a very predictable manner. So they spread via those lymph nodes. If they get beyond the lymph nodes, they can go almost anywhere in your body. You can get cutaneous melanoma mets almost anywhere. So we see them in radiology, in the heart, in the pancreas, in places, in the thyroid, places you don't normally see metastatic disease. So liver-only metastatic disease in cutaneous melanoma is actually very uncommon. The other thing to state is cutaneous melanoma is very sensitive to lots of the new immunotherapy drugs. So checkpoint inhibitors, ipilimumab, pembrolizumab, those kind of drugs. These patients have got good therapies coming online now. Now, if you flip that over to ocular melanoma is a much rarer cancer, so 5% of melanoma cases overall. Primary disease, is uncommon, average age 55. There is quite a high rate in Scandinavian countries, as there is in Ireland. And we're not quite sure why, whether it's Celtic genes, whether it's fluctuations in UV exposure. But so it is an important disease. The one thing to note is the globe of the eye. So the eye itself has no lymphatics. So because it's got no lymphatics, it can't spread to regional lymph nodes. So when eye cancer spreads, it spreads hematogously, and it spreads almost uniquely to the liver. So 90% of patients who have metastatic disease from uveal melanoma will present with liver disease and liver-only disease. In terms of working out who's going to get metastatic disease, that comes down to genetics. So what about the primary? Where do you get the primary? Well, we talk about the posterior chamber of the eye, so the choroid, the back of the eye, 80% of tumors, or anterior chamber tumors, so ciliary body or the iris, slightly less common. And the symptoms are quite vague: blurred vision, flashing lights. I joke sometimes this is related to a hangover. I should be careful, I'm drinking a glass of red wine. But the reality is the symptoms are vague. How do you manage the primary? Well, we don't need to worry about that. There's good hard evidence that's come from the North American group, the COMS group. So that's a collaborative group looking at a uveal melanoma, and they call it ocular melanoma in the US. And what they've shown is that the three mainstays of treatment, so you can enucleate the eye, you can cut it out, particularly if there's extraocular spread, so it's spread beyond the globe of the eye. You can treat it using these radioactive beads, radioactive seeds, iridium seeds, or you can do a biopsy and place one of these tantalum markers. They place these alongside the tumors and then use proton beam therapy to give local plaque treatment. The primary treatment has no impact on survival. What it does do is it offsets different complications related to the primary treatment. So in determining the treatment of the globe, you're really just weighing up side effects of the treatment. What patients want to know when you see them is, am I going to die of this? Is it going to come back? And we've got really good data again from the Liverpool group. So the Liverpool group, Bertel D'Amato and Sarah Copeland. So those are one of our primary uveal melanoma centers in the UK, have come up with this called the LUMPO, L-U-M-P-O, or Liverpool Uveal Melanoma Predictive Online score. You can get it online. And what you do is you put in the basic TNM demographics, thickness, depth, size of tumor, and that will give you a basic profile of the tumor in terms of its chance of coming back. But to get a real insight into the tumor behavior, you need a biopsy or you need an enucleation. And that will, particularly with chromosome 3 analysis, have you got monosomy 3, tell you the likelihood of the tumor coming back. Once you know the likelihood of the tumor coming back, then you can make a decision about whether or not this patient should have surveillance or whether or not you can discharge them from care. And one thing to note is the risk of the tumor coming back spreads out towards 10 years. So it's not like some tumor types like colon cancer, other things where you can say after 5 years, you're disease-free. What we do, patients that are at high risk, we will treat them with, or we will follow them up with MR scans. So you can be nihilistic, so a lot of people are. You can say, once you've got liver metastatic disease from uveal melanoma, the prognosis is bleak. 1 year survival is very bad, up to 10% in some series, and the gold standard of care used to always be said to be dacarbazine. Now, dacarbazine response rates are about 15%. So you really, in that setting, can see a logical argument for not pursuing following these patients up, because if you don't have an active treatment, there's no point in detecting disease early. Now, we would say that has changed radically. From angiography, so when we started treating these patients 10, 15 years ago, we were treating them with certain tastes. What we know from that data is that if you've got that nodular, porcine metastatic disease, that easily definable tumor, those patients do well. So their prognosis is much better, out towards 2 years here in this paper. If you've got what I call the measles, so lots of little disease spread out through the liver, their prognosis is bleak. So on angiography, you get a good handle how well these patients are going to treat. The other thing with uveal melanoma is be very careful. We can massively underestimate the disease extent on imaging, on CT and MR. Often I'm called to theatre for a liver resection. You see, even though we've seen very little disease at MR, the disease is completely replaced with tumour. So be careful. You don't want to treat a patient who's got more than 50% liver replacement. Now, what local regional therapy should we be using in these patients? So I've told you about DELCATH or chemosaturation, which I think is the gold standard, and I think most people would agree now. The other two options on the table would be TACE, so drug-eluting bead TACE, or radioembolization, or CERT. So the evidence for for chemoembolization, lots of small series. Most of the data show survival up to about 8 to 10 months. There are a few odd trials here which show very long survival, but when you drill down on the data, they have very, so the Vogel data and other data, they have very limited disease. So in a centre like ours, we would be, if someone's got very limited disease, you can aim to cure them with ablation, with surgery. They shouldn't be having a palliative treatment. And I think that's where that data has come from. They've used the treatment in patients in other centres would have been treated more aggressively. But the overall message is There's very little evidence for DEB taste, drug-eluting bead taste. And of course, the danger is these patients have normal background livers. So they're at real risk of getting biliary injuries, a bit like those patients with neuroendocrine cancer when we treat them with taste. So if you're going to treat them cautiously. And I would say treat them in a unilobar, fashion. Treat one side, treat the other side 6 or 8 weeks later. Where are we with CERT? So there's data both for resin and for glass for TheraSpheres. We've used both in uveal melanoma patients at Southampton. The data again shows slightly better survival, mixed populations, but they're showing survival out towards 18 months in the trials that are available. None of it's randomized and prospective though. What we've found in Southampton is, yes, both are well tolerated. We've found TheraSpheres are better in terms you can increase the dose you deliver, so you can allow for dose escalation. We've retreated one patient with uveal melanoma, but obviously you've got to be careful because the background liver has already sustained an injury. We've used DELCATH following CERT, so patients have been inserted in other centres, have come to us and had chemosaturation. That doesn't seem to be an issue. But in our practice, we would reserve CERT for patients who, because of cardiac risks, are at higher risk of chemosaturation. So chemosaturation does have an impact on your hemodynamic system. So we do use predictive markers to decide who is safe for the treatment. If we think people are at really high risk, then we would consider CERT as a safer treatment or an alternative treatment. Now, cholangiocarcinoma, I mentioned this because this is another area which there's a lot of active interest in the treatment. We've had no experience at Southampton, but I'll try and give you an insight into what's going on so far, although we're very excited about its role. I would say our 300 cases have all been uveal melanoma, and that just reflects our referral pathways and practice. So as you know, cholangiocarcinoma, 3% of worldwide GI malignancies, increasing in incidence, and there are very discrete patterns of disease, aren't there? So you can see a distal stenotic tumour down the level of the neck of the pancreas, treated in our centre a bit like a pancreatic head tumour. We can get those sort of bismuth-type bifurcation tumours, perihilar tumours, which are difficult to manage, often require multiple biliary stents. And then we get those mass-forming intrahepatic cholangiocarcinomas, which are the ones I can see certainly get pushed our way for CERT, for taste, for other things, and I think will be ideal candidates for chemosaturation, specifically because you don't have the issues of biliary drainage and sepsis. Prognosis from cholangiocarcinoma is poor, as you know. In terms of where we're at, surgery is the mainstay of treatment in terms of curative treatment, so you can cure patients with surgery. The problem is patients present late, and often the diagnosis is difficult to make. So once you've been resected, median survival, 28 to 30 months. So not bad, but the problem is very few patients are in a position to have a curative resection when they present. In terms of chemotherapy, I think it was the BILCAP study, I'd have to remind myself, BILCAP 3, but the mainstays have been GemCis. Now we've got newer drugs, we're starting to get some of the monoclonals, but again, the impact hasn't been huge. So this is a area of liver cancer which currently has limited treatment options if patients are irresectable. And therefore, there's a fairly compelling reason to look at liver-directed therapy, specifically in seeing we're talking about it today, chemosaturation. Where's the evidence? We don't have huge evidence, but in terms of experience to date with cholangio, the original data about chemosaturation prior to the original trial in America, I think about a quarter of the patients had ICC. So there is a paper here looking at 9 different European centres, looking at their patients who had had treatment, 15 patients being treated in the last line setting. They had 26 PHP. So this is one of the issues I would ask you to look at. So on average, we're only talking about less than 2 treatments per patient. So relative to the focus study, the current ocular melanoma study, where we're giving patients 6 treatments, these patients have been very undertreated, I would say. In terms of the results, they've got complete response 7%, partial response 13%, stable disease 53%. So this is what we're aiming for. What we're aiming for is getting disease stabilization in patients. And even though they're using less than 2 cycles in these patients with cholangiocarcinoma, they're demonstrating good tumor response and good control of liver disease. And that's, I think, all you can ask for a liver-directed therapy. Median survival, 26.9 months from diagnosis, 7.6 months from first PHP. So obviously these were patients at the end of their treatment pathway. They received very limited treatment because obviously we're giving less than 2 treatment cycles. And that's the issue. We need to be pushing the treatment cycles to the initial therapy. Another paper here, the Hanover paper. They're looking at 60 patients, 30 with ocular melanoma, 14 with cholangio, and some primary liver cancers, HCCs, and other secondaries. In their terms of overall response rate and disease stabilization, so overall response rate 33.3%, disease stabilization, that's, I think, that's what we're looking for, 70%. And again, they're showing in terms of progression-free survival, 4 months. So I think what we know is this treatment is effective at controlling liver disease. We know it's now safe, and we know there's emerging evidence in cholangiocarcinoma, when there are very few other treatment options, that this is an emerging technology which should allow us to get good disease control. The problem is the patients that received it to date have been undertreated. Quite timely, I went into PubMed today, so Franco Orsi's group, so I wanted to say the LOC, not the European Cancer Centre. Anyhow, the Italian group have published a new option for the treatment of intrahepatic cholangio. They're advocating the use of chemosat. And the very last line, I think, in their paper, I think is fairly apt. In conclusion, when disease is limited to the liver, chemosaturation therapy should be taken into consideration by an experienced MDT in order to add an effective weapon to our limited options. And I think that's very pertinent, very accurate. So in terms of EU experience with chemosat, majority of patients with uveal melanoma or ocular melanoma. The next group are cholangiocarcinoma, and then a spattering of other tumor types. So where are we at? Well, I always like to put this little table up showing interventional oncology is the 4th pillar of cancer care, and I genuinely think it is the 4th pillar of cancer care. I think we have a huge amount to offer patients with metastatic cancer. I'd say chemosaturation has evolved to being a safe and reproducible intervention. So we've done 300, we've had no deaths, and I feel confident any centre that invests and develops a multidisciplinary team who are all engaged can deliver this treatment safely with a minimal length of stay, without the need for intensive care. And in terms of efficacy, I think the treatment demonstrates excellent disease control in the liver. And I think that's all you can ask a liver-directed therapy to do. I think the signal was there back from the original Swedish data in doing this technique surgically. And I think we've now demonstrated we can do it by a percutaneous or minimally invasive technique. And the advantage of that is we can reproduce it, we can repeat it. So in the focus study, we've been treating patients 6 weeks apart, 6 weeks in between cycles, and none of our patients have dropped out because of side effects. And what our early quality of life data we're just about to publish shows is that the treatment has no impact on quality of life. So that for a patient with palliative metastatic cancer is a really important part of why this treatment is attractive. So I would say in terms of ocular melanoma, interventional oncology is now the mainstay of treatment, and I would say chemosaturation is the gold standard, or the treatment of choice for patients who have inoperable metastatic disease. The FOCUS trial data is out very soon. I was hoping it'd be out in time to give you a bit of a flavor of it today, tomorrow. But no, it'll be another few weeks, I think, but it is just about to come out. And I think that will ignite a lot of interest in this technology. Certainly our experience of FOCUS study patients was that they treated very well. The other thing is NICE guidance is just about to be published. That's the UK guidance on safety and efficacy. And the ESMO European guidelines on ocular melanoma, we're currently writing, they'll be out. It'll probably be another 4 or 5 months. So there's a lot of movement in that field at the moment. And hopefully that will give us an opening to start developing this technology around Europe. Well, thanks, guys. Thanks for your time. I'm going to go back to my red wine. I hope that's been useful for you. And I will be available for a bit of a question and answer session. If technology doesn't work, this is my email address at the bottom. You're always welcome to send us a message, and hopefully I'll be able to answer your questions. Thank you very much for spending the time listening to us.